and even PPEs. Governors have failed us. Let's see another one here. Mutiga says most counties are far from adequately prepared to handle COVID-19. Also to note, isolation beds are not the only necessary arsenal to contain the pandemic. Adequate and affordable protective material should be considered. That is what you're saying here on Twitter. Kindly use the hashtag NEWSNIGHT at Trevor Mbija at Citizen TV Kenya. We'll sample your views in this broadcast. We want to find out from Professor Omwan Zala, who's joining us live. He's a professor of virology and immunology at the University of Nairobi and also a member of the COVID-19 case management team. Prof, thank you so much for making time for us and for being patient. So, from the research you have done, how many people will have been infected by the virus when Kenya reaches its peak? We are currently at 14,000 plus.
Yeah, you see, the projections we did are actually projections, but the true number is just a reflection, because we were predicting maybe 1,000, 2,000 per day for a prolonged period of time. So as we speak, for Nairobi, we have not really peaked as such.
So we are yet to peak as we speak?
Yes, for Nairobi, we are yet to peak.
So the projections
because the data yeah. we are actually seeing is the data from Nairobi.
Okay.
And as the infection will evolve, we shall actually see different counties peak at different months, because of the issues of introduction, because of the issues of contacts and the like. And I would like people to just concentrate and look at what is happening in Mombasa between the month of May, June, and now July. It will give you a very clear indication that something is going on in Mombasa, which is a clear indication that Mombasa reached its peak and is now slowly remaining steady there, and with time, we shall actually see Mombasa beginning to decline.
So then what parameters will the Ministry of Health use to determine a peak number? Because you're saying at 2,000, how then will you know that we have now peaked? How many will be infected at that time?
It will depend on several things. One of them, it will depend on ability to consistently test. It will also depend on ability to actually identify cases and contact trace. And then we shall be able to, through that process, be able to see a sustained number of infections coming in through a period of time. And then slowly we shall begin to see a decline. That will be an indication of a peak. But it will not be that now 2,000 is the peak or 3,000 is the peak. It will be a sustained number hovering around a particular number where the infections are not going too high, they're not going too low, for a sustained period of time, and then thereafter a decline.
So at that time, your projection number is that how many people will be infected? I'm insisting on that number because we are having erratic testing right now. We have sometimes 4,000 samples, sometimes it's 3,000 samples. So we have 400 numbers, 300 at some time. So at what point will we know that this number is big enough?
See, if as erratic as the numbers might be, the calculation and underlying, I would not want to say that it will be 2,000 or 3,000 because it's unlikely to be that. But we shall reach a level whereby we are sustained for a period of time. And that's when we shall know that we have actually hit our peak. And that will be for Nairobi. I'm not talking of the other counties because the counties are not yet there. And that's the time we shall be able to see a decline. So let me not concentrate on a particular number, because once we say that, then everybody then rallies around that number. That is the most important. That is actually not the most important thing in terms of how we are going to manage this outbreak.
So, Prof, having all that statistics in mind, would another lockdown be of any use at this particular point, now that we already know there's community spread?
Our advice was actually that we ensure that counties are very well prepared. And once counties were prepared, and I'm sure counties are now preparing, and many of them are clearly showing an indication that they are getting there, then there will be no need for a lockdown. However, having said that, if in any locality or in any county there is overwhelming of the healthcare system, there is increased mortality, then those counties might require to have some form of restricted movement to ensure that that particular infection does not spread to the surrounding counties. So the advisory is that counties must be ready to not just look at where the infection is, but to also be able to contact trace, be able to look at sub-counties, and be able to look for clusters to indicate to us whether there is any particular problem in this county, in this sub-county or the other. But really, where we are now, what we would advise is that can we sustain the non-pharmaceutical interventions? Can we sustain that at an individual level? And if we did, really, we will actually slow down the spread.
But what does a county that is ready really entail? Because just the 300-bed capacity is not enough, Prof.
No. That was the bare minimum, Trevor. There are 6 or 7 things the counties need. One of them is an emergency response team, a team that is able to identify the cases and at the same time teams that are able to actually contact trace all the people that have come into contact with that confirmed case. Number 2, we need a very robust community engagement and risk communication so that we want this information to go to the lowest level, that even at that lowest level, people understand COVID and people understand what is their level of risk. The third thing, we were saying that every county must have access to testing. Testing that is available, testing that has a quick turnaround time so that we don't have confirmed cases lingering around in the community before they are isolated. We also need to have public health measures, hand washing, masks, sanitation, distancing. All these things must be there, be communicated and adhered to. And then we have to have case management. In those isolation facilities, we must be ready. We don't just want beds. We must be ready to be able to take care of those who will have moderate to severe disease. We need oxygen. We need all those facilities available. And then finally, infection prevention control. We don't want our healthcare workers to get infected. So beds was just the bare minimum. All these things I'm spelling out must be there at the county. And the counties must be ready to report on a daily basis.
Prof, keeping all that in mind, is there really a county that is ready then?
Yes, to some extent, it might not be 90%, but to some extent, counties are at 70%, others are at 80%. So for us, let them not just concentrate on bed alone. They must concentrate on all these things because all this is what measures up to containment and mitigation.
So from that medical perspective, how many counties would you say are ready? So if you're using an average of 70%?
I would guess the last time we discussed what about last week, and we were being told maybe it's 30 to 40 counties are about there in terms of having all these measures that we have spelled out in place. But I think, Friday when the presidency has communication with the counties, I think more information will be availed as to the readiness of the counties.
And judging from the current viral trend, is there a possibility that our health system will be overrun?
That is my fear, Trevor, because as we speak, Nairobi is totally overstretched, and that is the case. But counties still have a lead time, other than maybe Kiambu, Machakos, and Kajiado, and you see those are the counties that are surrounding Nairobi, which is really where the major problem is. The other counties really have a lead time. And if they can actually work through this and mainly communicate the risk management and also communicate public health measures, then the issue is that they can actually slow down this particular infection and avoid the healthcare system being overrun.
But we seem to be in a catch-22, Prof, because there's no inter-county assistance at any given point. Because if Nairobi is overstretched and we're about to be overrun, we can't, for example, transfer some patients to Machakos or a neighboring county, because then that spreads the infection as we move along, and it's even more cumbersome, right? So what options are you exploring?
The options we are exploring were that, two, we have looked at the natural history of this infection in our own country. We now know that quite a number of patients, maybe 80 to 85%, who are diagnosed with COVID end up having very mild symptoms or remain asymptomatic. These are the individuals we are advocating for home isolation. And now home isolation has been rolled out. It has actually worked very, very well in Mombasa. So if that can also be rolled out in nearly all the counties, so that we know how we can isolate those who are asymptomatic, but as we isolate them home, also have a mechanism of monitoring them, that should they begin to get sick, we can get them to a healthcare. Then we shall manage. Mombasa is actually doing quite well in terms of that majority of their patients are now in home isolation. So that is actually the procedure that can help us to ensure that home healthcare facilities are actually not overwhelmed.
But Prof, do we know now whether asymptomatic patients also still shed the virus? Because they could still shed the virus even at home.
Yes, the idea of home isolation is to ensure that, first of all, the guidelines spell out clearly who can home isolate and who cannot home isolate. Those who are going to isolate at home must have the ability to have their own separate room, ability to stay away from the rest of the family for the duration of the infection, ability to have ability to have their own utensils, their own everything, so that they don't infect others. As far as we are concerned, asymptomatic patients are still shedding virus. So we are taking them home, not for any other reason, but for the reason is that they are capable of staying at home, isolating themselves without infecting their next of kin.
So, Prof, I know you're putting in a lot of research on this, and you've mentioned that counties sort of have a head start so that they can recalibrate and ensure that they're ready. Right now, we're talking about 14,000 infections plus. At what point will the numbers be so high that then you will advise the president for another lockdown?
I would not like to see that. I would not like to advise the president for a lockdown, because my position has always been that we reopen and we remain open. And that's why we say counties have a head start. We are not in a position to stop the spread of coronavirus, but we are in a position to slow down the spread. And if we just adhere to the measures that we are talking about, we are actually capable of slowing down the spread. The issue you are seeing now in Nairobi is because of increased contact. People are not wearing masks. People are going to places that are crowded. This is actually the effects of the numbers you are seeing in Nairobi. But counties can avoid all these things by just ensuring that all the measures that we have spelled out are actually put in place to slow down the rate of infection. And then the other most important thing, to ensure that we limit the number of deaths. And we can only limit the number of deaths by ensuring that we shield those who are vulnerable. And those who are vulnerable are actually known. So those are really the things we want counties to be able to do, but the country as a whole.
Prof, will we be able to test sufficient numbers to know the true picture of infections in Kenya today in a population of 47 to 50 million people? We only tested about 250,000. How many more do we need to test to ensure that we have a true picture? And are we going to be able to do it, considering we lack testing kits?
It's not even an issue of lacking testing kits, Trevor. Even if we had enough testing kits, the strategy of saying that we want to test everybody in Kenya is totally uncalled for, and it will not even enhance the response to this outbreak. What we want is a strategy where we test those who are suspected or those who confirm, those who have upper respiratory tract infection, and ensure that we isolate their contacts and test them, and ensure that we contain and mitigate and ensure that those people don't infect anybody else. We also want to ensure that we can have a triage in hospitals so that when patients are coming in, we have ability to triage to avoid patients getting infected within the hospitals, and our healthcare workers also getting infected within the hospitals, an ability to quickly test should there be an exposure within the hospitals and isolate, and then ensure that we can contact trace and isolate and quarantine those particular individuals. That is actually the strategy that we want to follow. Number two, you can never test enough. You can never test enough. And even trying to say you want to test all 47 million Kenyans is uncalled for. Because from the understanding of this infection, the people who present with who we identify, who have signs and symptoms, are just a tip of the people who are actually infected. There is a silent infection that is going on that we actually don't see, and that's what leads to what I say, that the curve will eventually peak and begin to decline. By the time it begins to decline, it will actually be an indication that majority of us, maybe 40% of us, have already had been infected, recovered, and we have built some level of resistance. And so there are less and less of us in the community who are susceptible. And that's how this fire will actually begin to subside. That is actually the natural history. So saying that we want to test nearly everybody is not called for, because we understand what is going on. Let us test when it is necessary, and let us test and do something about it in terms of contact tracing and isolating those who are actually infected, and ensuring, the most important thing, ensuring that we limit mortality as much as possible.
Prof, going by that analogy, then the peak is most likely not going to be in September, because when you say that 40 to 50% of us may have been infected, we are talking about 20 to 30 million Kenyans at least having been infected before the curve starts to flatten.
Yeah, but realize, Trevor, that the peak will not be the peak for the whole country. Realize what I told you, that counties are going to peak, or regions are going to peak at different stages of this infection. Look at what is going on in Mombasa. Look at what is going on in Nairobi. Let us look at what will be going on in Nairobi a month or a month and a half from now. And then look at what will be going on in counties. So let's not say that the country will peak at once. No, the country will peak in different regions at different times. So that by the time we are saying that Mombasa has peaked and is declining, then the population within that Mombasa town, maybe 40 to 50% of them, would have actually been infected and recovered. And then the number of susceptible would have reduced to a very low level, whereby when we use the word, we say R0, that R0 will be hovering around 1 or below 1, where an infected person might only infect one other person, or infect no person at all. Because now we are saying that our R0 could be around between 1 to 1.5.
So in that case then, Prof, when a county, for example, Mombasa, peaks and starts to now decline, isn't it safer then not to go there? Are you likely to contract the virus in a county that has peaked and is now declining, or are you likely to contract the virus in a county that is still heading towards the peak?
No, it just depends on how well, Trevor, you adhere to the measures we have actually put in place. Definitely, the less susceptible people there are in any given locality, the less likelihood that an infected person will infect another one. Because infection depends on the volume of susceptible people in any given locality, and those people coming into contact with somebody who is infected. So as we move on, and as the infection continues spreading, and as people more and more people recover, those who are susceptible will begin to reduce in size, and those who are not susceptible will actually begin to increase in number. And that's how we shall see that peak and actually that decline. And that's exactly what how the process will evolve. But as I keep saying, we must do everything in our ability to slow down this spread.
Okay.
To ensure that we don't get overwhelmed in our healthcare system, and also to limit mortality.
All right. Prof, you are a professor of virology. Just the other week or last week, but one, if I'm not wrong, we lost 2 patients who are young with no pre-existing conditions, which is worrying, because then are we now dealing with a different strain of the virus?
We don't know. And you see, this is the issue of medicine and the issue of what I always say, that we are similar, but we are not the same. The way a virus will respond in one individual is not exactly the way it will respond in another individual. And hence, that's why you see that although we say that those who get severe disease, moderate to severe disease, and even those who die tend to be those who are vulnerable. But in between here, you actually find individuals who get very severe, very moderate to severe disease who are not vulnerable at all. And this is also because of the heterogeneity in how we respond to this virus. So I'm not really surprised with that kind of phenomenon.
Okay. Prof, now there's a vaccine that the Oxford University is trying. In fact, the UK has already ordered 90 million doses of the same.
True.
Should we do the same here in this country?
You see, I've been in the field of vaccines for years, Trevor. Vaccines take a long time to develop. Vaccines are actually the best weapon against infectious diseases. I know that the African Union has set up the African Union Consortium to begin to discuss provision of these vaccines in Africa. But my advocacy for vaccines for COVID is at 2 levels. One, that I want to advocate for the Ministry of Health to quickly and immediately set up a COVID vaccine consortium in Kenya, or a committee, or whatever name they like to call it, to begin to discuss how we shall introduce a COVID vaccine in this country. Because introduction of a vaccine and a new vaccine, requires planning, requires preparation. And realize also that we are not talking of a childhood vaccine. We have experience in this country in providing vaccines for under 5. But now this is a vaccine that is going to be given across the board. And just planning and prioritizing who should be given first and how it will be done. It is unlikely that there will only be one product. There are several platforms that are being used. Oxford is just one of the many vaccines. There will be several. There could be 2 or 3 vaccines that will actually be available. So that committee will be charged with the responsibility of looking at what vaccine
Yeah.
and the logistics and the movement.
Are we in the race for one of our own here from Kemri?
I'm not sure whether Kemri is actually developing a vaccine. I'm not sure about that. But the other thing, Trevor, I'd like to talk about is that we must also be involved in the clinical trials that will actually lead to a safe and effective COVID vaccine. And the reason why I say that is that vaccines are known to respond differently in different communities. So we also want to be able to understand safety. We also want to be able to understand its immune response. We also want to be able to understand its efficacy in our own setting before that vaccine moves to phase 4. Because phase 4 is when now you begin into the issues of effectiveness and logistics and the issues of distribution. I know there's been a lot of vaccine skeptics in this country saying that they won't participate, can't participate, but it's actually that is a wrong approach to take, knowing that vaccines will be the best weapon and will be a game changer in this outbreak control.
Having been in the field of vaccines for a while now, Prof, how long then should it take for a vaccine to be developed and be administered to populations that are as many as Kenya?
If everything goes well,
yeah,
preclinical work, usually that's where the antigens or the immunogens, adjuvants are developed. Animal studies are actually done. If all goes well, that could take maybe 2 to 3 years. If you move into clinical work, phase 1, if it's done well, safety is good, immune response is good, might take you 2 years. Phase 2, looking at dosage and various schedules of it, and also looking at extended safety, might take you another 2 years. And then now you get into phase 3, where you are looking at efficacy, big trials, 2,000 to 3,000 individuals, follow them for a period of 5 years. So if everything actually goes well, it might take you 8 or 9 years. But what is going on with COVID is that there was already pre-existing information that had come from SARS-CoV-1 and MERS-CoV. And a lot of some of these platforms had already been developed because we have been trying to get an HIV vaccine for a very long time. So the platforms that are actually being used are platforms that were being tested for various vaccines for HIV. So they were already available and their safety profiles were already known. And then also, phase 1 and phase 2 are being expedited, where you can do a phase 1, a phase 1B. Phase 2 and phase 3 can also be expedited, where you can do a phase 2B.
Yeah.
And as you do that, then the manufacturing plant is actually being put in place and resources are actually being mobilized to actually bring in and begin to think of how those doses will actually be made.
Okay.
So that's why people are saying that if all goes well, maybe by December this year or early next year, we might actually have a product that will go into phase 4.
Okay. Prof, we are pressed for time here, but I'd like to pose some few questions from the viewers here. Mwaki Peter says, will those patients who will have contracted COVID-19 be viable for vaccination when the vaccination process begins?
No, those are really the questions we are ask ourselves. Vaccinating an individual who has had a prior infection can either be yes or no. Because if they already have immunity that is preventing them, immunity that is protective, then they will not need a vaccine. But the question we should be able to ask is that, is your protective immunity good enough, or can we boost it? And those are the questions that we really need to answer during these processes of phase 1, phase 2, and phase 3.
And
yeah. So those are the issues.
Okay.
And this is some of the work we are beginning to do. We are following up post-COVID recovered patients just to understand their immune responses, to see whether that, again, immune responses is protective. Immune response may be there, but not protective at all.
Okay.
We have seen that with HIV. HIV, they have antibodies, they have T cells, but those T cells do nothing because the infection, they never clear that infection. So those are the issues that research, as well as phase 1, phase 2, will be able to uncover as we go along.
Okay. Chezake here is asking, will we need vaccines if we already peaked through the country and we're now declining?
The answer could be yes and no. For me, it will still depend on how protective the immunity in those who have recovered is. And we may only know that if we really follow and look at this immune response and even compare the immune response in those individuals who have recovered and the immune response that is going to be elicited with the vaccine. How are they the same and how do they differ? And at what level are they protective? We have actually seen vaccines where they give you protection for only a period of 6 to 7 months, where you still have to repeat again. So these are really critical questions that we must be able to understand as we think about introduction of a COVID vaccine.
Okay. Prof. Ferdinand here is asking if we are where we are relative to what was expected, or there are some factors which have influenced the current numbers that we're reporting.
Let me try and understand the question. If we are, say that again, if we are where we are.
Are we where we expected to be right now, or some factors influence the numbers that we're seeing as we speak?
You see, from where I sit, the numbers we are seeing in Nairobi are the numbers we should not have actually seen. And we adhered to the measures that we have been put in place. Because Nairobi is actually, the healthcare system in Nairobi is actually getting stretched. So we want to slow down the rate of infection as much as possible. So what I would actually say that true, the outbreak is evolving, but we are seeing a surge in Nairobi, and this surge is not the surge we would have liked to see. We would have liked to see numbers of those who are being infected, because definitely people will have to get infected because of just the nature of this infection. But we would have liked to see a slowed, rate of infection so that we can manage the outbreak very, very well in our hospitals. Those who need isolation can get isolation. Those who need to be put in ICU can be put in ICU. That's why we talk about a slow rate and a manageable rate and flattening the curve.
Okay. Wanaomi Mike is wondering, what is the secret that Tanzania is applying that we can't copy them?
I wish I knew what is going on in Tanzania, Trevor. I don't know. And I can't speak for Tanzania. I wish I knew. If I knew, I would actually use the same secret in Kenya. But I don't know at all what is going on in Tanzania. And
there's another question here. Is there any case of COVID-19 survivor who has been reinfected?
Yeah, there have been reports in Asia. There have also been reports in Europe. There have also been reports in the US. And the question is whether it is a reinfection or whether it is a rebound. So we must make that distinction, because some viruses, we still don't know everything about COVID. Some viruses have a propensity to, even when you recover, these viruses might remain latent in some cells within the body and only begin to rebound for whatever reason at a later date. We are not sure whether SARS-CoV-2 will behave like that. So those are the issues that we must follow. But there have been cases where people are saying, is this a rebound or is this a reinfection? And that then brings in the whole issue of an immune response. Because if you had a protective immune response and you have recovered, then you should not get reinfected.
So the difference here then is what exactly, Prof? Because it's a bit technical there. It means when you get infected, you should recover and should not be reinfected, or is it a new strand that now infects you?
It's not necessarily a new strand, because I don't think that with the information that I've seen, the information we are gathering, that this virus has mutated to an extent where it is escaping immune responses. No. What I'm saying is that once you get infected with COVID and you recover and you clear the virus and you have a protective immune response, you should not get reinfected. On the other hand, we don't know whether there is a phenomenon whereby you recover, but there is some remnants of the virus, what we refer to as latency, where the virus remains in latent cells quiescent and only again rebounds by beginning to replicate. So that is not a reinfection. That is a rebound.
All right.
That's what the distinction is.
All right. Prof, thank you so much for making time for us this evening. Professor Omwanzala, member of the COVID-19 case management team and also a professor at the Department of Medical Microbiology at the University of Nairobi, is a professor of virology and immunology, says that we're going to peak at different times, but the key here is in taking care of yourself. Sanitize, wash your hands as much as possible, cover your face with a face mask, and avoid unnecessary movement as well. That's where we leave Newsnight for now. My name is Trevor Mbij on behalf of the entire team and Wilson Mushora, who's been our sign language interpreter tonight. Good night and see you again tomorrow. Bye for now.
Sound institution providing tailor-made services to add value to your life, time and money. We are Stima Sacco, a true reflection of you.
Bahako mchanga ulizani zitamea zikuwe mob.
Hii historia mimba ya